Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hi, I'm Dr. Annie Luetkemeyer. I'm a professor of medicine at San Francisco General Hospital at UCSF. Welcome to Clinical Clips in HIV. This is our final summary of the conference data released at IDWeek in 2025 here in Atlanta, covering October 21st through October 22nd. Thank you for joining us. So we're going to cover a number of abstracts that talked about the role of long-acting antivirals both for HIV treatment and for PrEP. And I'm going to start with a study that is following on some of the data we discussed yesterday, talking about both lenacapavir use in PrEP, adherence, as well as drug-drug interactions. So this looked at the Purpose 2 study, and in this analysis, they looked at adherence in the setting of alcohol and substance use disorder, as well as did some modeling around drug-drug interactions with fentanyl. So starting with the alcohol and substance use disorder piece, of the over 2,100 people who were enrolled, 40% reported binge drinking and 37% reported drug use, excluding the use of marijuana. Now, the drug use was mostly stimulant use, about 20%, and only 1.6% reported opiate use, and less than 1% reported injection drug use. Now, the overall adherence at week 52 was excellent, more than 90%, and hearteningly, it was equivalent to this rate in those with binge drinking and in substance use disorders. So we did not see any impact of ongoing alcohol or substance use disorder on adherence to lenacapavir used as PrEP. The second piece that I wanted to highlight from this abstract was the physiologic pharmacokinetic modeling of a drug interaction with lenacapavir and fentanyl. And what they found in this PK analysis is that a weak interaction was predicted. So their conclusion was that there was no clinically relevant drug-drug interaction predicted in people using lenacapavir who also have fentanyl in their systems. This is something that we're going to want more clinical data on, but in terms of PK modeling, I think this is a very reassuring start. So I want to switch gears and talk about the use of lenacapavir, not as a PrEP agent, which it's been recently approved for, but in its role as a salvage therapy for those who are heavily treatment experienced. And I'm going to talk about some real-world data from the OPERA cohort. And as we know, the OPERA cohort enrolls about 15%, represents about 15% of people living with HIV in the United States, over 100 clinics and over 150 people living with HIV. And what they did in this analysis is they followed people who were enrolled in this cohort from 2022 to 2024 who'd received one or more lenacapavir injections. And this amounted to about 116 patients. These people had been living with HIV for quite some time. The median was 16 years living with HIV, and about 64% were virologically suppressed. So only about a quarter had a viral load of greater than 1,000. I want to point this out because this is in distinction to the Capella study. And remember that this study had only about 72 individuals. They were all viremic at the time of enrollment, and they had a lot of resistance. So this was a very specific population that we know a fair amount about for lenacapavir use, but it's really important to move on and understand how lenacapavir is working in the real world setting. So when we shift back to the OPERA cohort, which was reporting on today, the first point to make is that a little over half of individuals who started lenacapavir were able to simplify their regimen when they started this new injectable in addition to their optimized background regimen. For the primary outcome, 91% remained on lenacapavir and 9% stopped. And when we talk about the viral outcomes, for those who started virologically suppressed, the 12-month cumulative probability of suppression was 92%. For the small group who started when viremic, and that was about 39 of these individuals, there was a 76% probability of suppression, which is good. It's not as high as we would like to see. And unfortunately, we don't have details on the outcomes of len continuation or resistance in those who did not suppress. One other piece of, I think, heartening news here is that in general, in this real-world setting, nearly 90% of individuals had on-time or early injections. 11% were late, But one important piece to point out that of the 11% who received late injections, the authors point out that the majority of these individuals did not receive bridging medications. This is a really important piece to counsel our patients who are taking lenacapavir either as PrEP or for HIV therapy, that if they have an interruption in their lenacapavir, it's important to take oral bridging therapy, either with lenacapavir if that can be provided, or with another appropriate agent until they can resume their injectable schedule. So in a similar retrospective observational cohort from Chicago and Pittsburgh, looked at lenacapavir use in highly treatment experienced patients. And this cohort was slightly different in that more than half started lenacapavir while they were already HIV viremic. They'd been living with HIV for a long time, a median of 24 years since their initial HIV diagnosis, and importantly, about a third had reported a history of substance use disorder. At the end of follow-up that they were reporting, 89% remained on lenacapavir. In the group that started while suppressed, which was about half, there were no virologic failures, which is very encouraging. In those who started viremic, 82% of them suppressed. So I want to talk about the use of injectable therapies, in this case cabotegravir and rilpivirine, in two really important subpopulations, the aging population and those who are living with renal failure. So the first abstract I want to talk about is from the relativity cohort. This provides us with some interesting data on cabotegravir-rilpivirine use in the aging population. So this is a Spanish observational cohort of a little more than 3,000 individuals, and here they reported on the 11% that were over the age of, that were 60 or older, about 370 individuals. They reported on people who started cabotegravir-rilpivirine in 2024 or prior. Now, importantly, everyone who started cabotegravir-rilpivirine was virologically suppressed at the time of starting injectable therapy. This was mostly a male cohort. They'd been living with HIV for a long time and been on ART for a median of 18 years. There was not a lot of virologic failure, so less than 5% had had any viral failure. Only 6% had 2 or more ART mutations. So this was a pretty virally susceptible group that had been well controlled. In this abstract, they reported on follow-up for a little over a year. And importantly, they found less than 1% viral failure overall when they were looking at both those under the age of 60 and over the age of 60. And when focusing in only on those over 60, there was only 1 virologic failure. So I think very heartening to show that cabotegravir-rilpivirine worked very well in this older population. Overall was very well tolerated and highly effective in a population of older adults who were already suppressed at the time of cabotegravir-rilpivirine initiation. I want to end with an abstract that reported on an area where we really can use more data, and that's the use of cabotegravir-rilpivirine in severe renal impairment. So this was a small but I think really informative cohort of 12 patients. They were all virally suppressed. They had no prior treatment failure or suspected cabotegravir or rilpivirine resistance, and they started injectable cabotegravir-rilpivirine with stage 4 or 5 chronic kidney disease, including 6 individuals who were already on hemodialysis. Their primary endpoint was looking at virologic suppression at week 48, and the 11 who were alive at week 48 had virologic suppression. Unfortunately, 1 individual had died from an MI prior to week 48 that was unrelated to antiretroviral therapy, but unfortunately we know that there are higher cardiovascular mortality outcomes in this population. Renal function, while they were on cabotegravir-rilpivirine, was stable, and hearteningly, 3 individuals underwent a renal transplant during this time, and their renal function, as expected, improved during that time. They did a nice PK analysis that looked at cabotegravir and rilpivirine levels in these individuals with severe renal impairment, and the cabotegravir and rilpivirine levels were consistent with what was seen in the registrational trials, affirming that no need for dose adjustment and that we can have confidence in prescribing cabotegravir and rilpivirine to our patients with really severe renal impairment, including those on hemodialysis. So helping to fill out our real-world data on how we can use these really powerful injectable agents, including in those with some severe morbidities. So thank you so much for joining us here in Atlanta for IDWeek 2025. Please remember to click on Continue to complete a brief post-test evaluation to get your continuing evaluation credit. Please also return to the activity page to view our first clinical clip from IDWeek from the first 2 days, as well as our homepage for other accredited HIV activities. Thank you again.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and select Continue to move through the post-test and evaluation questions.